of you. The third plenary of the day. May I introduce the speaker who needs no introduction to this audience. However, Professor Tan Arulampalam. He is an accomplished laparoscopic colorectal surgeon from United Kingdom. He was working as a consultant surgeon at Colchester General Hospital from 2003 to 2022, and he was the clinical director of the Assini Institute for Laparoscopic Surgery, one of the premier institutes in United Kingdom, and he was heavily involved in laparoscopic colorectal training as well. He has now diversified his expertise to human factors in surgical safety, which is a very important area that we need to address, and also medical research as well as healthcare process and delivery. He has trained many Sri Lankan surgeons and has been an ever-willing collaborator with College of Surgeons of Sri Lanka. Over to you, Tan.
Thank you very much, Bhavantha. Thank you, Professor Lamawansa, and President and the Scientific Committee for inviting me. Yeah, I'm fine. Yeah, I'll do that. Thanks. Okay. So technology has now beaten me. I'm not sure what you've just done there. It's okay, let me sort it out. Okay. Good. I'll do it. Okay. So I have some disclosures, none of which... Do you want to do the talk? Okay, I'm fine, honestly. Okay, I better just... Okay. Is it projecting? Yeah, okay, I'll just turn it off. So I do have some disclosures. None of them are relevant to the talk. And what I'm going to try and focus on is low cost, high impact educational resources that we can use to train our new surgeons, but also that we can use to continuously educate those of us who are in the middle and later years of our training, because continuous training is really, really important. Have we got... Yeah. Okay, good. So, disease is very old and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. So medicine has changed a lot, and I'm going to talk about some of the immersive technologies. I've worked very closely with Hamish Mackenzie and Jordan Sigarides, both technologists and clinicians who have far greater understanding of virtual reality and digital assets. But I've had to learn, as you will have to learn, because this is the future. They filmed, edited and disseminated lots and lots of virtual reality projects, and this is part of what I'm going to talk about. So I'm going to look at what the world looks like now, talk a little bit about extended realities, look at the playbook for how we can apply this for our training, and most importantly, this can be applied in the Sri Lankan setting, because very often people come and talk about technologies and the expense is too much. And then I'll look a little bit at the horizon. So we know from the work of Birkmeyer, you're all familiar, that the top quartile surgeons have fewer complications, fewer medical complications, and fewer readmissions into the hospital. And the lower quartile similarly have much higher complications. So what goes on in the black box of the operating room is incredibly important. And there are many, many publications confirming this. We all know this, but the one thing we don't do is measure what goes on in the operating room. or the measure we have of success is that your patient comes in alive and then gets into the recovery room with a pulse. And we know that complications are very much related to the level of training, but training involves surgical learning curves that are very different for different types of trainees. And the skill sets amongst our trainees, and in fact amongst our consultants, varies very widely. So we have to understand about expertise. And it's very important. I mentioned how important it is to train our consultants, because if you get arrested development, if you're a consultant in 2024, what you don't want to be is the same level at 2044. I can remember when I was appointed, my chief said to me, I don't want you to be the same surgeon in he mentioned 24 actually, as you are now. So it's important that we keep growing. I've mentioned general practitioners, and I'm conscious that I'm married to one, but this is about the measurement of skills, surgical skills, as it were. And it's really important because we have to assure technical competency continues across your career, not just when you're in your training years. And unless you have a learning health system that involves adequate design, good implementation, continuous improvement, you will not achieve these things. This has to be a continuous thing. So I don't know whether any of you have read Edwards Deming. Edwards Deming was an industrialist who, after the Second World War, actually helped the Japanese speed up their industrialization. He was a systems thinker, and he talks about understanding variation as the main cause for process and outcome failure. And we don't do that in surgery. We have a complication, we talk about it at the M&M, and the same thing happens 6 months later. We need to appreciate that we're working in a system. We have to appreciate the theory of change, understand leadership psychology, and continuously look for improvement. So just to give you examples of what our world was like. This was the inauguration of Pope Benedict XVI in 2005. And this was the inauguration of Pope Francis. Okay, you can see that there's one smartphone here, and look at how the world has changed. Knowledge can spread virally, and the people have changed. So my daughter will build her world using Minecraft, and she will adapt and go to her learning needs, not what I tell her. And it's very interesting. You can probably spot me in the background there. This is what our classrooms look like, but my daughter's classroom looks like this, where people are looking at problem solving, team working, flexibility, and those sort of areas are what we should be looking at for our trainees. The whole world was involved in a huge experiment where 1.5 billion children were taken away from school. And we learnt very quickly that actually using digital assets, which were low cost and very high impact, if they were done well, could really move the dial, move the needle. So I'm going to talk a little bit about augmented reality, mixed reality, and virtual reality. So let's talk about virtual realities, where the digital environment shuts out the real world. Augmented reality is where the digital content is placed on top of the real world, and mixed reality is where digital interactions occur with the real world. And I've had my VR headset, which is somewhere around here, and some of you have had a play with it. But it's very, very interesting. So learning anatomy for our medical students now is very different. This is Jordan teaching anatomy at Norwich Medical School, where we can actually interact in 3D. So no more reading the anatomy textbooks and spending a long, long time drawing out the 3D images. And this happens in musculoskeletal, all the systems basically. We can really get immersed in the anatomy so that the learner can understand the anatomy without having that rote learning need. So you can accelerate learning. But more than that, this is James Kinross, and I visited him at Imperial with my daughter, and we put on the HoloLens. Now, HoloLens is expensive, so these big form factor bits of hardware are changing. So now the Apple glasses are like lenses, but they're extremely expensive. Over the next 5 to 10 years, as happens with all sorts of industrialization and innovation, the costs will come down. So it's possible to apply these clinically now. So these are plastic and orthopedic surgeons reconstructing, trying to find those perforators, which often is very, very difficult to do. They've co-registered CT images so that they can now work in augmented reality to spend as little time as possible to identify their needs. So we can use augmented reality not just for training, but also for clinical applications. So let's look at virtual reality. You know, this was the virtual reality machine that we started with, and you know, in the 80s and 90s, this is what we had. Big form factor, very heavy, large battery packs. And this is what we are coming to now. This is me doing an operation at a trade fair. So the form factor is changing. We are going smaller and smaller, lighter and lighter, with better battery packs, so that we can actually wear these without any problems in your head and neck. So the spectrum of virtual reality goes from the less interactive, which is just 360-degree video, to the most immersive, which is computer-generated virtual reality, and there are places in between. So if you look at the 360 video, this is where a clinical interaction is happening, and our students can actually witness this. Now, in terms of giving people equity of access to these resources, you can send this out, or you can beam this very cheaply just with an internet connection. If you go to the 360 with interactivity, then you can put learning assets within the movie, so that, let's say you're doing an anterior resection and you want to know a little bit about the stapler, then you can have a movie on the side so that the learner can go and find what they want. And computer-generated VR is quite scary, and I'll just show you some examples. But the Royal College of Surgeons looked at this in some detail, and they really stated that technology-enhanced surgical training was to be a key focus. So this is something that not only is happening right now, but all the authorities and college bodies in the UK certainly feel that this is important. So we go from books to traditional video to virtual reality. And actually the way we work is changing as well. So if I can give an example, I think if any of you were at the AI symposium yesterday, you saw how important the onboarding can be with a virtual reality. So this is a training video from CMR Surgical. So you have to do these online modules and actually be immersed in the operating theatre before you lay your hands on the physical machine. So your cognitive rehearsal and your muscle memory is made up before you actually have to use the machine. So this means there's less transportation of people. The face-to-face sessions can be really very, very productive, because you're not wasting time getting to be familiar with the equipment. Now, I'm sure most of you will be familiar with the Kirkpatrick levels. When you're learning, you have to look at the reaction. Did the learners enjoy the learning? Did the learning transfer occur? Did training change behavior? And did the training influence performance? If we do any learning, this is how it should be designed. And this is Jordan. He's putting on his VR simulation, and actually a lot of the work has shown that in terms of Kirkpatrick levels, virtual reality hits all the buttons really in an excellent way. So this is an onboarding for a radiology simulator. So you can learn how to use the equipment before the expensive equipment turns up, because time is money in our hospital administrative systems. Now, making the content in VR is actually quite cheap. So that's something to think about. But we can also use it to train. Now, this is a simulation of a child in the accident department, and they come in with a fever. And you can see that as time goes on, you can measure the performance of the task, and it's decreasing. You can look at what the extraneous, as you increase the extraneous cognitive load, the performance decreases, and we can look at all sorts of other factors. So if I run the simulation, so this is in VR, the person wearing the headset has to make
Doctor, what do you want to do?
they have to make decisions. So the person wearing is now looking round, chooses the instrument tray, and so on and so forth. And when you measure it, you see that the stressful experiences in VR induce the physiological responses that we feel in terms of heart rate, blood pressure, and cortisol. So this is really, really a very good way of training. And note, this isn't a surgical simulation, this is a scenario, a clinical scenario. And we can do this. We've started to gamify our training. So this is scrub games, and we actually run the simulation in reality. So we play a game. I don't know whether any of you youngsters are familiar with escape rooms. So this is a surgical escape room. And we can put the surgical escape room onto a headset. And you can play with other players, not necessarily physically next to you. So we take away physical boundaries. Now, if you do this, when you have that stressful situation where a patient has a post-tonsillectomy bleed on the ward, actually everyone is aligned to understand what their roles may be and what could be happening. They've had that cortisol level, they've had that heart rate rise, they've had all of this done previously. And I've built some simulations for some of the operations that I do. I did this with Carl Storz for EPSIT. So this is 360 video with some interactive areas. So actually you can now do an EPSIT procedure for pilonidal sinus without ever having come into my OR. There's some knowledge base that you can learn. So what I've done is I've projected it as if you're the learner wearing the VR goggles. And it's quite stunning now using AR. This is another one that I made for using the stapler. And if you look at this, we showed it to some Ukrainian surgeons. Again, low resource setting, and the reaction was quite amazing. You can see he starts praying. He can't quite believe how realistic it is. So it's very interesting. But we can do other things using technology. This was a project that I initiated with Revolve Labs. We had to train some surgeons in the Caribbean. These were consultants. We had to train them to use a robotic camera holder for semi-robotic procedures. And what we did was in the UK, we set up a laboratory. We used Teams. Okay, so it's not an expensive platform we used, and we had some videography, and then we had the experts. So we're still very valuable as human resource, and we trained the surgeons who set up the same lab, a twin, in the Caribbean. We did several sessions, then we did a mock-up, and then on the 21st of September 2021, 6 Caribbean surgeons did 6 operations without me physically ever having made contact with them and trained them on the kit. Now, they could have abandoned the operation, the governance around that was all there, but the point, what we were trying to demonstrate, is we can do remote training if you have the right methodology. And this was extremely successful and picked up. Now, this is all very nice. I've shown you some nice videos, but does it make a difference? Well, if you look at virtual reality versus traditional learning, the knowledge gain is high. If you look at VR more interactive versus normal VR, the knowledge gain is very good. And if you look at VR versus other digital education, you can see the knowledge gain is high. And the same applies to skills. So when this is looked at, let's use a non-surgical assessment tool. So PricewaterhouseCoopers are an auditor, so they won't take any nonsense from us surgeons. There's a 275% increase in confidence to act once you've been through a VR simulation program. It's 4 times faster than the classroom. It's 4 times more focused and 3.75 times more emotionally connected as a learner with what you're learning. I have never once said that we eliminate the face-to-face learning. This is part of a hybrid program to enhance and accelerate learning. So, as such, you know, we have started using a lot more cadaveric training. So this is obviously face-to-face. But my learners now all go through a VR program before coming to the lab in Newcastle, which means they have the knowledge base and they have the understanding of what the lab looks like, they understand the lab rules. So we spend a whole day doing what surgeons love doing, and that's operating and learning. So what about AI? Well, I have, since 2002, several terabytes of video saved of my laparoscopic procedures. Have I watched all of those videos? No. And the reason is it takes time. So what we can do is we can set the AI using computer vision to auto-navigate to points of interest. So I've set this lap chole video assessment to look for hemorrhage. So what will happen is if you look at the bottom scale, it'll look at the whole operation and just pick points where there's been hemorrhage. Now if I'm with my trainee, or if I'm with a peer, we can go to the 6 or 7 points where there's been bleeding, and rather than the slightly aggressive confrontational feedback, we can actually give nurturing feedback, which is much better for learning, where we say, what do you think happened there? And the surgeon can say, well, I used the hook at the wrong place. And you can say, why did you use the hook at the wrong place? And you can actually get a really rich learning process, and we know the benefits are huge. We gain proficiency much quicker. We can actually have insights and self-reflection. We can we can decrease the number of complications when we put people through these programs. And actually AI for computer vision in a practical sense is really interesting, because you need to register, when you're building up the AI programs, you need to register your instrumentation, then make sure it all happens with segmentation, and then you can get a situation where this is a colorectal procedure where the computer vision will direct you to where certain anatomical structures are. Now, a bit like driving, most of your cars will have some sort of guidance, whether it's park assistance or telling you that the tire pressures are low. We're using assistance constantly, and what I would say is AI is not the finished article at the moment. We should use, as I said yesterday, weak AI to help with some of our tasks. We can't take the human away, we must keep the human in the loop. Now, the most exciting thing is the remote learning project that we're doing with the College of Surgeons, with SLAMADS, with rods and cones. This is a smart glass project where the operator wears the smart glasses. The kit is put in securely into the back of the laparoscopic stack. All can be used with an open frame, and then we can use it to mentor our subjects. So this is what I, as the trainer sitting in England, may see. So I might see what's going on, and if I forward it a little bit. So then we get deep down, and I, as the trainer, can then direct the person doing the operation to say, actually, you need to just look at this. So on the screen, you have to do a few areas to share, and then I can direct the trainer. Now, if what this stops is people having to get on the road to physically be in theatre with your colleagues. And this program, I'm really proud to say, is coming to Sri Lanka. So you can do this to actually mentor trainees that you have trained, or to collaborate with colleagues, or to run classroom sessions. So we could have somebody operating in the UK or in Colombo, beaming their operation here. They can carry on without us interrupting them, and we can moderate that operating session. And so this program is going to be launched in Sri Lanka with funding from the Dutch government, which I'm really glad that we've got. We've got funding for 8 kits, and I think this is going to revolutionize how we interact and train. Again, this is low cost, high impact learning. And this is just an example of, once the program is up and running, then Professor Bawantha can sit in Colombo and then help direct a trainee, a colleague who is maybe doing a difficult case in the periphery. So it will save on travel, it will save on environmental footprint, etc. So I ran a classroom with a surgeon operating in Poland. I had 20 students from all over Europe, and Professor Budzinski was not interrupted by us unless we decided that we wanted to ask him. So it takes away that hazard and jeopardy of live operating, which I think you have to be very careful. So what's coming up next? Well, every company is trying to get into healthcare. So you've got to just forget about being a healthcare person now. Most of these companies are companies that are software, digital companies that happen to do a bit of health now. So the metaverse is coming in all sorts of ways, not just from gaming, but seriously into the medical world. So I ran a metaverse project with J&J, using some trainees and looking at ward rounds, rare and complex cases, and they're able to wear these glasses and then interact. When I was training, I had to get out of bed every Saturday morning and go and do a ward round with the boss, whereas now these people can do it asynchronously. They can do it whenever they want to. And this can be quite frightening. This is just an example of what mixed reality looks like, where the digital world interacts with the real world. This one's a bit of fun, but I will show you what happens when you do it surgically. So in Korea, they did a project with 200 surgeons from the Asian Society, Asian thoracic surgeons, and they trained them in the metaverse on lung cancer resections. 200 surgeons. Can you imagine doing that sort of training at scale? So each surgeon had their own avatar, they could interact, they could ask questions. It was a really enriching program, and I would urge you to read the paper before you make any judgment. And in terms of coaching, we can look at how surgeons are training, look at eye tracking, looking at how their hands are moving, and this all is very, very key to good outcome surgery. So I'll come to a conclusion. You know, we need to focus on our surgeons, we need to work in teams and really focus on human factors, but also data is gold now. Data is what will change our surgery. You can't be too busy to change. Whatever we do, we have to bring it into a surgical safety management system. We can't just introduce these things. We have to study, and we have to go through the plan, do, study, act cycle. So if we want progress, we have to change our mindsets. The visible world is no longer a reality, and the unseen world is no longer a dream. This is a quote from W.B. Yeats, which I think is very apt for us as surgeons. So thank you for your time, thank you for inviting me. I would not be able to do some of the crazy things that I do if it wasn't for my wife supporting my surgical career, so thank you very much to her as well.
Thank you very much indeed, Professor Tan Arulampalam. No questions are allowed in this plenary. However, please give me half a minute to state few things about the lecture delivered. within a very short period you covered a lot, but is relevant to the current surgical practice and training with the technological, how to use the technological advances. And also the message you gave is clear to us that even in low cost setting these things could be applied. And I hope that the bringing this kind of technology will help us to reduce the variation in the competence level achieved by surgical trainees and young surgeons. And perhaps this exposure to this kind of training will reduce the cognitive tiredness of the surgeons through operating session. And beyond these comments, your involvement in bringing that technology closer to our trainees is highly appreciated, sir. Thank you very much indeed for that effort. With those few remarks, shall we once again put our hands together to appreciate a nice lecture delivered in this morning.
Thank you, sir. To recognize his invaluable contributions to our session, I invite our chairpersons, Professor M.D. Lamavansha and Professor Bhavantha Gamage, to present the token of appreciation to our speaker, Mr. Tan Arulampalam. Thank you, sirs. To award the certificates of appreciation to our chairpersons, I cordially invite Deshamanya Professor A.H. Sharif Dean. Professor M.D. Lamavansha, and Professor Bhavantha Gamage. Thank you, sirs. Ladies and gentlemen, a small announcement. The symposium